Okay, so welcome to the fourth session of the webinar series on genetic services in Appalachia. We ask that you mute your microphone for the talk and place any comments or questions in the chat. We ask that you not record our session. We will be recording the session and providing a transcript on our webinar website. And we had a little bit of delay due to the holiday and some illness for our third session, but those should be posted by the end of the week, if not in the next day or so. At the end of the session today, we'll ask you to complete an assessment to give us feedback. And we sent around, for those people that are registered, we sent around information on an evaluation for our last session. So we ask that you please provide that if you are able. And as you know, for this survey, genetic services in Appalachia seminar series, our aims include to develop a research agenda for genetic services in rural Appalachia. Each month, we will be having speakers who are working in genetic service provision in medically underserved populations, most of them being in the Appalachian region. And our ultimate goal is to develop a research focus to improve the quality of care in genetic services in Appalachia, and also, to the extent that we can in West Virginia. So we've had 3 sessions so far, and those are available on our website. But now I would like to introduce Ms. Alyssa Bovee-Terry. Ms. Terry is a genetic counselor in New York State and has been working with the federally funded NIMAC, New York Mid-Atlantic Caribbean Regional Genetics Network, for the past 6 years. And she will talk to you more about what that is and what exciting opportunities they have for us. Currently, Ms. Terry serves as a project director and telegenetics navigator for NIMAC. Ms. Terry received her BA in biology from Cornell University and her Master's of Science in genetic counseling from Johns Hopkins University. Ms. Terry has worked in various capacities for the genetic counseling program at the FAIR Institute since 2006. So at this time, Alyssa, if you would like to share your screen, we would be thrilled to learn more about your NIMAC and the work that you're doing, especially in telegenetics and genetic service delivery to underserved populations. Thank you.
Perfect. All right. Well, thank you so much for that introduction. I look forward to being with all of you today and sharing some information about our organization. I do not have any conflicts of interest. As Kim just said, I do work under a federal grant from HRSA. So as was said in the beginning, NIMAC stands for New York Mid-Atlantic Caribbean. Our region includes 10 states and jurisdictions, which I'll just do in telehealth in the coming slides. This type of billing is usually pretty straightforward for physicians and often also for physicians' assistants and nurse practitioners. So they kind of take the code that they would have used if they were seeing the patient in person and just add a telehealth modifier to that. So it can be pretty straightforward for the most part for those providers. Genetic counseling billing for telegenetics is often influenced by how the institution bills for in-person services if they have both. So because genetic counselors are not recognized by Medicare, some institutions never bill any insurance companies for genetic counseling, even though many private payers do pay genetic counselors. So if that's the case, that typically impacts the way the institution is willing to bill for telegenetics. So basically, we always tell people if your institution is not billing for your in-person care, they're probably not going to start billing for telegenetics. But what happens is sometimes this question really prompts the institution to go back and look at why they're not billing for their in-person genetic counseling. So the two are, if The clinic offers both in-person and telehealth. The way you bill is typically aligned between the two practices and influenced by the choices that were made about in-person care. Facility fee and incident to billing are used a lot for in-person care, especially with genetic counseling, and are often not applicable for telemedicine, although in some situations a distance site facility fee is allowed. Some payers will pay an originating site fee if a patient comes to a clinical site. So if they walk into their pediatrician's office, there are some insurances that'll pay the pediatrician's office a small amount of money for their sort of assistance in that effort. Providers may sometimes assign their billing rights to another site and allow them to do the billing. So you might have a geneticist at West Virginia University who's doing some care, and instead of West Virginia University doing the billing, they assign their billing rights to, a maternal fetal medicine clinic, and they just do the care. And the maternal fetal medicine clinic pays the geneticist by contract, but they don't actually bill the insurance. That's sort of a complicated way of arranging things, but it does exist sometimes. So outside of insurance reimbursement, we do see contract models where the specialist is paid by contract from another group. Again, we're thinking about maybe an oncology practice, maternal fetal medicine, cardiovascular center. And it's usually a substitution for those places having to hire their own genetics provider. So the paying group, say the oncology center, benefits from better patient outcomes, from eligibility for credentialed center status. So there's some national credentialing sort of titles that you have to have the availability of genetics in order to qualify for. So sometimes that's why an oncology center would be seeking a genetics provider. It helps keep patients local, reduces errors, and again, generates downstream revenue, as I talked about before. In those contract models, sometimes no insurance is billed, and sometimes this can be affiliated with assigning billing rights, like I mentioned before. Some genetics providers do freelance work under these models, and numerous telegenetics companies exist that work under this type of model, again, where the genetics providers don't work for a hospital or a health system, but rather just do telehealth under a contract. Thirdly, a lot of grant funding is available right now for telehealth because of the COVID pandemic and the importance of telemedicine then. So there are a lot of programs that have benefited from obtaining some of that grant funding. It's a great way to get started, but we definitely encourage centers to plan for sustainability over time. And lastly, some telegenetics programs rely mostly on direct billing to patients. So they don't bill insurance, but expect families to pay directly, which obviously can be a big barrier. So a few final notes about planning. Planning a program can be pretty complex and lengthy, or if a pandemic happens, it can happen very fast. Our planning guide hopes to provide structure, support resources, and a checklist to our genetics providers. We are available to support providers through the process, and we encourage our regional providers to contact us for more information. So lastly, we're happy to be able to provide funding to some groups for telegenetics. We're now up to 11 groups that we have awarded telegenetics funding to, and we do see big increases in their planning scores and many patients seen by those programs. We have funded or have plans to fund programs in every single one of our jurisdictions and try to make sure that those programs are specifically reaching underserved communities. And we're lucky to receive great feedback from some of the groups we have worked with. You can see some of the lovely things that people have shared with us about NIMAC support, especially during the transition to telemedicine during 2020. So we're really happy to know that the support that we had provided to our genetics providers and clinics really helped them make that transition more quickly than they maybe would have been able to do had they not been engaged with us. So as I mentioned, NIMAC is part of a nationwide system of regional genetics networks, and all of those networks provide support for telegenetics. Here you can see the work that's been done nationally over the past 3 years with regard to telehealth training at the top, education in the middle, and technical assistance on the bottom. So this is happening not just in our region of NIMAC, but across the country with all the regional genetics networks doing this type of support. And as you can see here, there has clearly been a huge jump in patients seen by telegenetics in the supported sites across the nation. We're glad to see that a lot of those families are indeed coming from medically underserved areas. So I also want to make mention of some of the other work that NIMAC does that touches on telehealth in some way. We are in the process of establishing teams in each of our 10 jurisdictions. These are made up of diverse stakeholders, and we have a great team in West Virginia that some of the people on the call today are in. And I think I saw somebody from our Maryland team on today as well. I thank you guys for being here. So these are teams that are set up eventually in each jurisdiction to help us understand the key barriers and solutions to improving access to genetics in the state. So each NIMAC team defines their own local challenges and potential solutions. Thus far, our work on the teams has produced an infographic and social media campaign in New York, an educational program for existing staff that work with families in Virginia, and a family video testimonial project in DC. Some of the NIMAC teams may choose to focus on telegenetics if they deem that to be the most relevant issue to their state at the time. NIMAC also includes the territories of Puerto Rico and the Virgin Islands as of 2020. We're working on very similar goals there. And due to staffing shortages and obvious challenges to traveling for care, a key goal in the territories is also to design a culturally effective model for telegenetics. So we have been aware that we need to design things pretty differently there than how telegenetics works here. But we're hopeful, and we're working closely with some amazing people there to see what we can do to improve access to care in the territories. This is our NIMAC flyer, which outlines all the programs that I have talked with you about today. The link is on the side of the slide there. You can find it easily on our website as well. And I just wanted to share a few other notes about really useful resources. So as I stated, the other regional genetics networks have great resources for telegenetics as well. The Southeast region has a telegenetics work group. The Midwest has some great patient telegenetics videos. Western states has a huge collection of videos, online resources, and the training program. The Family Center has that infographic that I shared earlier, and our national group has a full resource repository that includes these telegenetics products. These are all freely available, and I encourage you to explore them. NSGC and ACMG also have a lot of support and resources for telegenetics. Both organizations are currently working on publishing recommendations for telegenetics. They include telegenetics in their education planning and supply a lot of resources. So I encourage you to check there as well. Some clinics have incorporated other technology beyond telegenetics, including things like chatbots to answer questions, online family history collection tools, various databases and risk calculators, and even using artificial intelligence in some settings like facial recognition to predict potential diagnoses. So sometimes these health IT applications are integrated into the telehealth program. Sometimes they're sort of a side project that goes along with both the in-person and the telehealth, but it's been really interesting to see the evolution of these other technology applications in genetics. It's also key to point out that the family engagement is vital to planning and implementing telegenetics. NIMAC and the other regional networks all emphasize family engagement and were greatly supported by the Family Support Center. We have definitely seen that the more the new strategy is informed and tailored by the community, the higher the likelihood of success is. And that's very true for us in our work in the territories we've noted, and we're doing a lot of work in West Virginia right now too. So lastly, I'll share some other really good resources for telehealth in general that are not built specifically for genetics, but can still be very instrumental. So the Telehealth Resource Centers, as I said, are also federally grant-funded organizations. They provide assistance, education, and information for anyone interested in providing care at a distance. The Mid-Atlantic Telehealth Resource Center covers Virginia and most of the NIMAC states, but there are different telehealth resource centers that would cover some of the other Appalachian states. They do offer a number of fact sheets, online resources, office hours, annual meetings, and online forums. And I have the link there that you can either find Matrix if that's your home telehealth resource center, or using their map, you can find yours. The Center for Connected Health Policy serves as an independent center of excellence for policy. They provide technical assistance to all of the other telehealth resource center. So they sort of keep track of and organize all of the state laws and local policies that influence what can and can't be done by telehealth. And we're going to take a look at that on the coming slides because it's ever evolving, as you might imagine. And lastly, TTAC is also federally funded, and they kind of keep track of and assess new telehealth technologies. So they often review things like if a new electronic stethoscope that can be used over telehealth comes out, they might check it out and do sort of a short video on how it works. So you can go on there and sort of look at their reviews, their innovation watches, and they provide assistance to organizations that are trying to make purchases or selections in making choices between telehealth products. So again, telehealth policy can be really important, and telehealth resource centers, as well as the American Telemedicine Association, do a great job of keeping track of those policies. So just some of the things that can influence the way you build a telehealth program will include state licensure policy. So typically, a medical provider needs to be licensed in the state that the family is located while they're talking to them. That only applies if there is licensure for that profession. So there is no licensure for genetic counseling in some states, including West Virginia. But for physicians, for example, if they want to talk to a family that is in Pennsylvania and the provider is sitting in West Virginia, they oftentimes need to have a medical license in Pennsylvania. On the next slide, I'll talk a little bit about how that changed during COVID. Similarly, a lot of telemedicine requires credentialing at other institutions. If you're going to connect one clinic to another, sometimes your specialist, your genetic specialist, has to be credentialed at the other institution. Medicare has some very specific rules about who can do telemedicine and how it needs to be done. Again, a lot of those rules were relaxed during COVID, so we'll talk a little bit about that on the next slide. A lot of state Medicaids have their own separate policies, so they don't necessarily align with what Medicare says. They have their own set of rules about both who and how telemedicine can be done. The private payers may have their own set of rules about what they will reimburse in terms of the codes and the types of providers. Some states have specific consent policies that if a family is receiving a telehealth consult, they have to have a specific consent just for the telehealth visit, so above and beyond the consent that they're providing for treatment. There are privacy and HIPAA regulations that need to be kept in mind when you're doing telehealth, and also fraud, use, and abuse policies. So certainly nothing that I say, and the Center for Connected Health Policy also says this should never be considered legal advice, but it's useful to keep in mind the various types of policy that would impact a planning process. So we have seen a lot of policy changes with COVID and the need and demand for telemedicine solutions. So there were changes over time in that previous policy, including Medicare, used to require that families that receive telehealth had to be located in a rural location. That has changed, at least temporarily, so that pretty much all patients are eligible to receive telehealth regardless of where they live. The type of site that the family was in when they talked to their specialist used to be limited by Medicare to only clinical sites, so the patient could not be at home, with a few really specific exceptions. Again, that's changed during COVID, as we all know. A lot of families have received telehealth at home. We don't know what the long-term policy is going to be there, but as I said, the previous Medicare policy did not allow patients at home to receive telehealth and be reimbursed for that. The codes that were billable for telehealth used to be much more limited than they have become now during COVID. So when you're thinking about billing codes and what is happening with the patient from the hospital perspective, there's a lot more eligible codes now. Similarly, in some situations, there were only specific providers that were allowed to provide telehealth. So maybe in some places only physicians could do it, and none of the nurse practitioners or PAs or genetic counselors or anybody else could do telehealth. And we've definitely seen that expand. States oftentimes have specific policies requiring their payers to pay for telemedicine. We've seen that increase over time, and that you can check your state on the Center for Connected Health Policy with regard to that. We've also seen during COVID a relaxing of the rules around HIPAA and consent. So there's no explicit HIPAA policy that's just about telehealth. It's really just about making sure that your telehealth system maintains the same confidentiality that you would have in person. But we have seen, certainly during the very height of the pandemic, doctors much more likely to use their cell phone to do a video call, sort of whatever it took to get care to the patient. So we did see that relaxation happening. I think most people expect it to go back somewhat to be a little more rigid, but I think a lot of expectations are hopeful around continuing to have a little more relaxed rules around these things. Similarly, I talked about medical licensure on the last slide. A lot, I would say most states had very relaxed policies, at least at certain points during the pandemic, with regard to whether or not a provider who's talking to a patient in their state needs a medical license there or not. So for pretty long periods of time, our providers from Maryland could talk to a family in West Virginia or in Tennessee or wherever the family was without worrying about whether or not they had a license in that state where the family was. I don't think most people expect that to be an immediately permanent thing. There are some interstate licensure compacts that are being explored that would make it a lot easier for providers to hold multiple licenses. But it's certainly something that you always have to keep your eye on. If you're talking to a patient in another state, you need to know what the existing current policy is on whether or not you need a license there and if there is licensure there. There were some relaxed rules about whether you could prescribe certain medications by telehealth, as well as around fraud and abuse. We don't really know what the future will look like. I definitely rely heavily on the Center for Connected Health Policy. You can go right to their website, find your state, and find out what's going on. They keep track of policy that is being proposed. It's important for all of us that are invested in telehealth to play a part in supporting policies that will make things easier for families. So I think we're all sort of just watching and waiting to see what will become permanent and what might revert back to the way things were pre-pandemic. So a couple other resources while I wrap up. I mentioned the American Telemedicine Association before, but here is a link to their website. They also have annual meetings and a lot of resources. They are a membership-based organization. Some states or regions have telehealth groups that really watch closely and advocate for policies in the state. The American Medical Association has resources for telemedicine practice, as well as the American Academy of Pediatrics specific support resources. So that's really it for me. I really thank you for your time today. I encourage anyone in the NIMAC region to please consider joining us, to use our resources, to tell other people about NIMAC, attend our events, use our website. I encourage you to reach out to us if we can be helpful in your work. And with that, I'm going to thank you for your time today, and I am happy to answer any questions.
Thank you for that wonderful presentation. And my mind is buzzing and trying to process all of the different sources of information and all the potential directions that we can go in telegenetics. So thank you for that. And I'll also mention that Alyssa has been very engaged with us in at WVU in trying to learn more about our population needs, and has been doing some work in collecting information and trying to figure out how to best provide services, genetic services in our region and in West Virginia in particular. So I'll kick us off with a couple of questions, and then anyone else that has questions, we'd be pleased to field those. First, knowing your background and talking to lots of folks in our state, what do you see as the primary challenge for genetic services in rural Appalachia?
It's interesting. We, as an organization, we have started recognizing that we see three very common themes whenever we talk to any location that we work with. So we see themes under the bucket of distance to care, sort of where you are versus where the closest clinic is, and how you get from A to B, even if you're within the same city. Sometimes those issues can be really important. So distance to care is one really big one. We also see issues related to education about genetics. So whether the family has sort of enough health literacy to understand the value, if they're recommended to go to an appointment, they might it's not on their radar as a priority. And some families do have really important competing priorities. So we see education barriers both for the families as well as some of the providers in the community. So if it's the pediatricians or the primary care providers, just maybe not prioritizing genetics. So it's sort of that education bucket. And then the third is we typically see unique issues for each underserved community that we look at. So as you said, we've been looking really closely at West Virginia. We worked last year really closely with Virginia and DC and New York. And every time we have those conversations, there tends to be just really specific, unique issues that arise for people in that specific population. We work with Amish and Mennonite families in Pennsylvania that obviously have really different barriers to care than other families. So a lot of the work that we do is really to keep trying to collect experiences and stories from across the state to understand what that is. And it's never going to be possible to design a genetics healthcare system that optimally addresses all of those problems. But I think we can all explore ways to be more flexible in the way clinics provide services, to participate in community-based and provider education just to raise awareness about genetic services. The issues around bringing providers into the state, I think, is a problem probably across a lot of the states in Appalachia, just not being able to fill genetics provider positions or fund genetics provider positions is a huge barrier. And I think a lot of the professional organizations are trying to provide resources to convince institutions to have more positions for genetics. And I think sometimes the advent of telehealth also allows some of those positions to be filled by people that, providers that aren't ready to permanently relocate. So they can still provide some of the services by telehealth. So I think those are similar to the other areas of those issues of distance, of issues in underserved populations, and of education tend to be the biggest things that we try to address.
Yeah, and I think health literacy is a big one in Appalachia. I would agree. I mean, I grew up in more western part of Kentucky, and my family is from Appalachia, but I had never heard of genetic counseling until I went to graduate school and started working with the BRCA mutations. Yeah. And my family has cleft palate, and they, had some financial challenges. So I think it is a big issue just knowing that there's someone that can handle these kinds of issues, and so that's something we're also working against.
Yeah.
Another question is, what are some of the opportunities you see for research to improve genetic service delivery in West Virginia and the region? So you talked about some of the other things that are going on, and certainly Dr. Fala has talked a bit about her work, but if you can just comment on that.
Yeah, and I think as we're typically not a research organization, we're less tuned in, but need to be more tuned in. So when we're talking about these solutions that we try to build, for example, if we're trying to improve the health literacy in a community in a way that would impact the likelihood of a family going to genetics, those are things that can be tracked and followed. If you're going to do some sort of health literacy campaign, let's try to find a way to keep track and to measure whether or not that actually improves compliance in families taking up the referrals that they're given. As you mentioned, we've seen even families that do receive services don't always follow through on the medical recommendations. So I think there's ways to look at interventions in that arena. What can we do in clinic to remind families, to make it more likely that they're going to follow through? So I think all these interventions that we talk about, even if it is something as simple as a social media campaign, we need to be cognizant of finding ways to keep track of whether it's actually working and making an impact, because if it does work, those are programs that can be expanded more broadly. If that doesn't make an impact on making it more likely that families are going to get into care, then we shouldn't keep investing money in doing those things. I think there's obviously been work done over the years in demonstrating the value of having a genetics visit for a family. Like you mentioned, if a family has a history of cleft palate, what is the value for them in going to a visit? But maybe that needs to be studied more specifically in the region, just to be able to demonstrate really concretely why it brings value to the system and to the family for them to go to care, to sort of convince institutions that it's worth it, both to the institution and to the family. A lot of times we do see genetics providers or even genetics clinics being on paper looking like they're kind of losing money for the institution because of the billing situation. But a lot of places are able to document that there's all these other impacts on families and downstream with the institution that argue for the value of genetics. So I think for places that are really struggling with having enough genetics providers or having institutional support for genetics providers, maybe taking a look again at really documenting and demonstrating why it matters, what impact it has, and how it does benefit the institution, even if it's not in the immediate billing cycle.
Thank you. Does anyone else have any questions for Ms. Terry? Okay, and certainly if you have additional thoughts, we have an evaluation, and Anusha, if you could post that in the chat, and we would appreciate your feedback about this. If you have additional questions, we're working with Alyssa a lot these days, and appreciate the good influence she's had on increasing service provision in our state. And it sounds like other regional genetic networks are doing great work in that area as well. And I certainly am indebted to the progenitor, I guess, of NIMAC, which was Margin, and that helped me set on this path. But if there are no additional questions, I'll thank you, and we will be in touch.
Thanks so much.
Thank you. Oh, wait a minute, there's something here. Let's see. Regarding added value, there's one comment from Dr. Kaler.
Oh, that's great.
Yep, that's how you pronounce my name.
Well, thank you. That's
that's
always
great.
encouraging.
Yeah. Of course, the money was spent by genetics and surgery and radiology,
Yeah.
not the income.
Yep. Exactly.
But yeah, the more targeted we can get in our approach to helping people, where we're not having to, run a lot of different types of tests, and we can kind of zero in, that certainly helps too.
Oh, that saves a lot of people money.
Yeah.
Mhm. All right. Well, thank you very much. We appreciate
you.
your engagement.
Nice
today.
talk. Thanks so much.